بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. Welcome everyone in this night in one of our Saudi Society and Saudi Society of Nephrology and Transplantation activities. So as usual, we continue delivering our scientific activities. I hope you will enjoy this activity tonight. Just a quick announcement before I leave the mics, Dr. Muthanna, our moderator. So the CME hours will be earned automatically and electronically for the target audience only, and those who have active Saudi license, Saudi Council of Health Specialty license, and it will be electronically and for those who attended all the meeting. So if you attended all the meeting and you have the active license and one of the target audience, you will earn the CME hours electronically. Without further delaying, I will give the mic to our the moderator today. I will leave him to introduce himself as well. He will introduce our valuable speaker tonight.
Thank you so much, Dr. Khalid. السلام عليكم وحياكم الله جميعا. كل عام وأنتم بخير. أسأل الله أن يبارك لكم فيما تبقى من الشهر الكريم. My name is Muthanna Sahlawi. I'm a nephrologist at King Faisal University in Al-Hassa. I would like actually to extend my thanks to the Saudi Society for Nephrology and Transplantation for providing such high quality scientific webinars that have continued effectively throughout the pandemic to serve the nephrology community and healthcare workers. As you know, diabetic kidney disease has been actually a very hot topic recently, especially with the groundbreaking trials in SGLT2 inhibitors and the new generations of Mineralocorticoid receptor antagonists. And in this regard, it's my pleasure to welcome Dr. Peter Ressing, who's a well-known clinician researcher whose work is devoted to diabetic complications, particularly diabetic nephropathy and cardiovascular disease. Dr. Ressing is the head of clinical research in diabetic complication at Steno Diabetes Center in Copenhagen University Hospital. I would like to bring your attention to the Q&A section where you can submit any questions throughout the talk, and at the end we will try to address all relevant questions, inshallah. And without further ado, I move the mic to Dr. Ressing.
Thank you very much, and thank you so much for the opportunity to talk to all of you. It's a great honor and pleasure to be invited for this meeting, and I look very much forward to presenting to you. As was just said, this is fantastic times. Unfortunately, on one hand, we have a big and growing problem, but we also have an exciting development with lots of new opportunities to combat chronic kidney disease in type 2 diabetes. Before I start, I'll share my disclosures. I've worked with different companies, and many of them have been involved in these trials, developing new or potentially new therapies for this condition, kidney disease in diabetes. Now, as you know, diabetes is a big and growing problem all over the world. We have talked about a pandemic or an epidemic of diabetes. And a few years ago, it was estimated that more than 460 million would have diabetes, and that this would grow in 25 years to more than 700 million, with growth happening in all parts of the world. And just a few months ago, these numbers were updated, and whenever these numbers are updated, it unfortunately goes in the wrong direction, meaning now it's 537 million that have diabetes, and it's expected to grow to almost 800 million in the future. So diabetes is a big problem, and diabetes is a major cause of chronic kidney disease. But although diabetes is a big problem, you as nephrologists will know that chronic kidney disease is an even bigger problem. And it has recently been estimated that almost 800 million people around the globe have chronic kidney disease, and death due to chronic kidney disease is an increasingly common cause of death, and it has now been the number 12 most common cause of global mortality. One of the problems with chronic kidney disease and diabetes and in other conditions is that very many people with chronic kidney disease are not diagnosed. We are not screening sufficiently well for chronic kidney disease, and in the early stages, as you know, chronic kidney disease is asymptomatic. So it is estimated that up to 90% with chronic kidney disease is not diagnosed. Is that a problem? Yes, of course, that's a big problem, particularly now that we have new therapies to offer to people with chronic kidney disease, because that means that people cannot get early treatment. As mentioned, diabetes is really a leading cause of chronic kidney disease, but there are also other cardiovascular hypertension leading to many people with chronic kidney disease. KDIGO is an organization which you know well. This KDIGO organization issues guidelines, and they recently had a conference on early detection of kidney disease. And they really want us to emphasize that screening for chronic kidney disease is important. If we screen for kidney disease, we have the opportunity to intervene early, and that would reduce long-term costs for care of end-stage kidney disease. So really important that we have new opportunities, but we need to implement them. We need to identify those with kidney disease, particularly those with diabetes, where the prognosis is really, really serious, as you of course all are well aware. That means screening, and it means screening with measurement of estimated glomerular filtration rate, but also measurements of albuminuria. And in many places, screening, at least in the diabetes population, with GFR measurements or creatinine measurements are performed on a more or less regular basis, but often albuminuria is forgotten. And of course, as you know, albuminuria is really important, because if you have declining kidney function or increasing albuminuria, then your risk for end-stage kidney disease increases, but also your risk for cardiovascular complications and for all-cause and cardiovascular mortality is increasing significantly, and hence the green color reflects that everything is good, whereas with declining albuminuria or increasing declining GFR or increasing albuminuria, you go to yellow, orange, or red, and thereby indicating the very high risk for these different complications. So very important that we look out for this. I shouldn't tell you, the nephrologist, this, but to my colleagues, endocrinologists and general practitioners, this is a particularly important message that we need to spread. Now, I was a member of the working group that issued the recent KDIGO guideline on management of chronic kidney disease in diabetes. It was published in October 2020. And this guideline, I will mention a little bit from that to outline what is actually current state of affairs in treatment of kidney disease and diabetes. The guideline focuses on what we call comprehensive care, on glycemic monitoring and glycemic targets, lifestyle interventions, anti-hyperglycemic therapies, an area where there has really happened a lot, because now glycemic therapies are not just lowering glucose, but many have very important kidney protective or cardiovascular protective effects independent of their glucose lowering effects. And then I'll talk about approaches organizational to management of patients with diabetes and CKD. But I'll also mention that last month we had an update of this guideline in public review. It's not yet finalized, but it was important already now to issue a new guideline because we got even more evidence with new agents, particularly the mineralocorticoid receptor antagonists, where we saw very exciting data with finerenone that I'll share with you as well. So as you know, the foundational therapy in chronic kidney disease with diabetes, as without diabetes, is blockade of the renin-angiotensin system. And these are 20 years old studies showing that angiotensin II receptor blockers in proteinuric type 2 diabetes significantly reduced the risk of progression of kidney disease and end-stage kidney disease, but also highlights that there is a very large unmet need or residual risk that we certainly need to address. And as you know, for the past 20 years, we have tried and tried in many different ways to find ways to reduce this residual risk, and until 2015, without any success. And then we started to see exciting data in cardiovascular outcome trials in diabetes, and later we got the aldosterone antagonist data. And suddenly, within the past couple of years, we have seen several new exciting opportunities, which I'll come back to. But in a nutshell, you could say that treating type 2 diabetes and chronic kidney disease is based on, as for any people with diabetes where you want to manage the disease, it's a healthy lifestyle, meaning exercise, healthy nutrition without too much salt, smoking cessation. And then it's about control of cardiovascular risk factors, meaning glucose control, blood pressure control, and lipid control. Then RAS blockade, as just mentioned, and then SGLT2 inhibitors came into the guidelines recently. And then in patients with chronic kidney disease, there's a high risk for thrombosis, so therefore antiplatelet therapy is often indicated, but there's also a high risk for bleeding with these agents, so we need to balance this risk and potential benefit. But this is what we need to do in all people with diabetes and chronic kidney disease. In terms of glycemic control, I will just say that improvement in or strict glycemic control has been demonstrated to be beneficial both in type 1 diabetes, but also in type 2 diabetes, particularly in relation to progression of the microvascular complications, eye disease and kidney disease, nerve complications, and not so much regarding cardiovascular disease, although there are some trends that improving glycemic control per se may also be beneficial for cardiovascular outcome. When we set the target for glycemic control in diabetes, as in anybody with diabetes, we need to set a target which on one hand is ambitious, particularly if there's long life expectancy and few comorbidities. But on the other hand, we should also be careful about the risk for hypoglycemia, and therefore, particularly if patients are treated with agents that can reduce or can induce hypoglycemia, such as insulin or sulfonylurea, we need to have perhaps a higher target as kidney function is declining. So compared to other tables of targets, you can see here on top severity of chronic kidney disease is included, because with declining kidney function, the risk for hypoglycemia is increasing, but of course only if you are treating with agents that can induce hypoglycemia. Regarding diet, it is recommended to have a healthy diet, rich in vegetables, fruits, grains, fibers, plant-based proteins, and to reduce processed meat and refined carbohydrates and sweetened beverages. And the different illustrations are trying to illustrate that we should put dietary recommendations into a social and relevant context for the person with diabetes. Otherwise, it's not possible for the patient to implement this in the daily routine and life. We also set some targets for protein intake. They are aligned with the World Health Organization target for protein intake of 0.8 gram of protein per kilo body weight per day for the general population with chronic kidney disease and type 2 diabetes. And then with the notion that if you are in dialysis, particularly peritoneal dialysis, then you need a higher protein intake because it's a catabolic state. And also there's emphasis on particularly plant proteins compared to animal proteins. Then also a word about exercise, or particularly avoiding sedentary behavior, which surveys have demonstrated is more prevalent in the population with chronic kidney disease and diabetes. So we need to pay attention to increase physical activity to 150 minutes per week. And of course, also be aware of obesity being a risk factor both for cardiovascular disease, for diabetes management, and for kidney disease. And therefore, we should focus on reducing body weight, particularly when GFR is above 30. Now, the big excitement, you could say, happened with the new agents that have shown additional new benefits. And it started with cardiovascular outcome trials with SGLT2 inhibitors and GLP-1 receptor agonists. The SGLT2 inhibitors were tested, and the first trial was with empagliflozin or EMPA-REG. These trials were mandated in type 2 diabetes with a history of cardiovascular disease to show that these new agents were safe from a cardiovascular perspective. And as I'm sure you know, there was seen a reduction in myocardial infarction, stroke, and cardiovascular death, or what's also called 3-point MACE, but also reduction in heart failure and cardiovascular death for some of these agents. And that was a success story, you could say. The idea was to lower glucose, but in addition, there was positive effects on the heart. And also very excitingly, particularly, of course, when you are interested in the kidney, was suggestions of kidney benefits with decline in albuminuria and less decline in eGFR and development of end-stage kidney disease, with importantly, quite good safety outcome or safety profile. But very interestingly, particularly because these agents were initially concerned to be potentially damaging to the kidney because you excrete more glucose through the kidney. Now, after the cardiovascular outcome trials, we got the first dedicated kidney trial in type 2 diabetes, which was Credence with canagliflozin, showing, you could say, for the first time since we had the studies with the angiotensin II receptor blockers 20 years ago, a positive trial in diabetic kidney disease. So this was presented in 2019, showing that we could reduce end-stage kidney disease, doubling of serum creatinine, or cardiovascular or kidney mortality with 30%. So really a significant and important outcome with canagliflozin in type 2 diabetes and kidney disease. And as you will remember, in that population, everybody had type 2 diabetes. They had a GFR in the range of 30 to 90 and an albuminuria above 300. And shortly after came the dapagliflozin trial, DAPA-CKD, which was expanded compared to Credence because it also included people with non-diabetic kidney disease. 1/3 of the population had non-diabetic kidney disease. And because the albuminuria range was a bit lower, down to 200 milligrams per gram creatinine, and eGFR was down to 25 in this population. So a somewhat broader population, and yet the findings of this trial, where I was part of the steering group, as I'm sure you know, found this highly significant 39% reduction, corresponding to numbers needed to treat of 19 with dapagliflozin compared to placebo, to reduce this event of 50% decline in eGFR, development of end-stage kidney disease, or renal or cardiovascular death. And if you look into the different outcomes, there was a kidney-specific outcome without cardiovascular death. There was a cardiovascular death or heart failure hospitalization endpoint, and all-cause mortality endpoint, and all these endpoints were significantly reduced in the DAPA-CKD population. And when you look into the different populations, you could say very intriguingly and surprisingly, because when we started the trial, we had no data in non-diabetic kidney disease, and yet the effect on all these outcomes, the primary outcome, the kidney-specific outcome, heart failure outcome, and mortality, they were just as good in the population without diabetes as in the population with diabetes. So this effect is not related to the glucose lowering effect, or at least there must be a lot of other factors playing a role. What about if you look at those in stage 4 CKD with GFR less than 30? There was almost 600 patients, and in that subgroup, there was similar benefit again on all these outcomes, suggesting that even in very advanced CKD, you'll get a benefit. And as you probably know, the EMPA-KIDNEY trial with eGFR down to 20 has just been stopped. We don't know the data, but the rumor is that it's a positive trial, again showing that SGLT2 inhibitors provide a good benefit. We don't know, of course, the details of the EMPA-KIDNEY, but it may provide details also on the normal albuminuric people with low GFR. What about the different subtypes of kidney disease? I mentioned that diabetes or no diabetes doesn't matter. And actually also, if you looked at the subtypes of chronic kidney disease in the non-diabetic subgroup, they all had more or less same benefit. Of course, some of these groups are quite small, but no significant interaction in these studies. So quite consistent findings. And also importantly, from a health perspective or societal perspective, is that it seems to be cost effective to implement SGLT2 inhibitors. This means that usually when you start a new therapy, it will cost more, and then you'll save or you'll get longer life or less side effects, better outcome, and you are agreeing to pay a certain price for this improvement in healthcare. But here you're actually saving money, and that's because for new therapies that are able to delay end-stage kidney disease, because end-stage kidney disease is so expensive, then a drug that can delay end-stage kidney disease or maybe even prevent it is going to be cost saving. So it's really important that we start these therapies. Now, what about GLP-1 receptor agonists? They were also glucose-lowering drugs tested in cardiovascular outcome trials, initially to show that they were cardiovascular safe. And they also demonstrated, at least in some of the trials with GLP-1 receptor agonists, that they reduced the cardiovascular events, maybe reduced atherosclerosis more than the SGLT2 inhibitors. And there was also some interesting findings from a kidney perspective with GLP-1 receptor agonists. These are data from some of the GLP-1 receptor agonist trials showing firstly that GLP-1 receptor agonists are good for glucose lowering, and here are from Pioneer with semaglutide and Award with dulaglutide, showing reduction in hemoglobin A1c. They also showed in the different GLP-1 receptor agonist cardiovascular benefits, and that was also seen if you stratify into the populations with chronic kidney disease. And then also, intriguingly, there was suggestions that there might be kidney benefits with less progression of kidney disease, maybe not in the overall population, but if you focus in post hoc analysis, so of course it should be taken with caution. If you focus on those with GFR of 30 to 60, then loss of GFR 30, 40, 50, or 57% corresponding to a doubling was reduced with some of the GLP-1 receptor agonists. And to test this really, if it's going to be good or bad for the kidney, there is right now a trial with semaglutide ongoing in a classic kidney disease trial with proteinuric type 2 diabetes being included. And the trial has recruited and is ongoing, and now we are waiting to see what will be the outcome of this to clarify and to demonstrate really in a dedicated kidney trial if GLP-1 receptor agonists have a role in kidney disease for kidney protection as they have for glucose lowering. So this is the updated algorithm from the KDIGO guideline, which was just in review, and it looks a bit like the one from October 2020. If you are sharp, you'll notice that now the lower threshold for starting an SGLT2 inhibitor has been lowered from 30, which was based on credence, to now 20 in eGFR based on the EMPA-KIDNEY, where we don't know the outcome, only that it has been going on. But we know from heart failure trials that starting down to 20 seems to be safe. And we have seen subgroup analysis from cretins and from DAPA-CKD showing that you could go down to 20 and still seem safe and efficacious from a kidney and heart perspective. And then the GLP-1 receptor agonist as the preferred glucose-lowering agent after metformin and SGLT2 inhibitors, which of course comes after you have initiated lifestyle therapy. This should be put into a context of a well-organized healthcare system, because a single physician will not be sufficient to handle this. So we need collaboration between different specialists, endocrinologists, nephrologists, cardiologists, and so on, but also between nurses, doctors, dietitians, and other specialists. Unfortunately, given these fantastic data on the GLP-1 receptor agonist and the SGLT2 inhibitors, it was a big disappointment to see these data from the US, where more than 500,000 people with chronic kidney disease were evaluated for use of kidney protective medication. And you can see that only 20% are treated with an ACE inhibitor or an angiotensin II receptor blocker, although these are cheap and has been recommended for more than 20 years. And also you can see GLP-1 receptor agonists and SGLT2 inhibitors, they are used in less than 1% of the population. And actually, the authors pointed out that more people are getting NSAIDs and proton pump inhibitors, which may be kidney toxic, than people are getting kidney-friendly medication. So indeed, at least in the US, we need to see improvements. Of course, you can say data may be different in different parts of the world, and I really hope that we are seeing implementation of these new therapies. And with that, I'll go to one of the most recent opportunities we have received, which is the mineralocorticoid receptor antagonists. They are interesting from the perspective that the mineralocorticoid receptor activation is important for heart, for blood vessels, for kidney, and for brain damage, because there are these receptors all over. They are activated by aldosterone and cortisol, which can lead to multiple complications. So therefore, if we can block this overactivation of the mineralocorticoid receptor, that may potentially be beneficial. And we know traditionally in the kidney that blocking this activation can be beneficial for reducing inflammation and fibrosis. And then you can say in the normal setting, we know that this receptor was well known for many years for its role in regulation of blood pressure and electrolyte balance. But actually, we have learned that it's much more than blood pressure and electrolytes. It's really important with the blockade and involvement in fibrosis in the glomeruli, in the inflammatory response in the kidney and elsewhere. So therefore, there has been more focus on this mineralocorticoid receptor and its role and the damage you can induce by activating this receptor. There are many factors, and diabetes being a very important one, but also hypertension, oxidative stress, high salt load, all these and other factors as well will activate aldosterone and the mineralocorticoid receptor, leading to kidney damage and heart failure and heart damage potentially. And of course, therefore, this is a potential interesting thing if we can prevent this overactivation of the mineralocorticoid receptor. Now, you also know that traditionally we have had for many years aldosterone antagonists, the steroidal ones like spironolactone and eplerenone, and they have not really been used in kidney disease because of side effects with potassium, and also for spironolactone, other side effects like gynecomastia. So therefore, it was very exciting when recently finerenone was developed as one of several new non-steroidal mineralocorticoid receptor antagonists, showing promising data in phase 2 trials some 5 years ago, showing that it was possible to see benefits with reduction in albuminuria or reduction of markers of heart failure with less apparent problems with potassium than we have previously seen with aldosterone antagonists, suggesting that the finerenone which reacts in another way on the receptor, and that could explain the different response, that you seem to get benefits of preventing overactivation of the receptor with less side effects. Is that really true, or could that really be true? And there was experimental data suggesting, yes, it is really something different when you use a steroidal or a non-steroidal mineralocorticoid receptor antagonist. And for instance, in cellular experiments, it was demonstrated that the genes activated or downregulated when you block the mineralocorticoid receptor are different, whether you use a compound like finerenone or the old traditional compounds like eplerenone. So something different is happening in the cells. So it's not just blocking aldosterone in the usual way. It is indeed potentially something different. And as mentioned in the phase 2 program, it was possible to show benefits on albuminuria. And there are also other aldosterone antagonists, at least in Japan, where there's this compound isaxarenone, which was able to reduce blood pressure and albuminuria. So indeed, a growing and exciting area. This is one of the few studies comparing spironolactone and finerenone in people, here in people with heart failure and chronic kidney disease, showing that spironolactone causes a lot more of hyperkalemia with the same extent of lowering of the surrogate markers of heart failure, and with less side effects on the kidney, but also with more effect on blood pressure, as you can see here. So finerenone seems to provide benefits, but less side effects. But of course, this is phase 2 trials. We needed large phase 3 trials to really test if this would pan out in clinically meaningful benefits in real-world trials. And therefore, Fidelio and Figaro trials were developed to test this, and these two trials were later combined into one combined analysis, because the two trials were very similar in design, and the combined analysis is called Fidelity. For both trials, Figaro and Fidelio, people had to have type 2 diabetes. They should be on maximal tolerated RAS blockade, and they had different degrees of albuminuria, from micro to macroalbuminuria, or moderately to severely increased albuminuria, and GFR from 25 and above. And not type 1 diabetes and non-diabetic kidney disease were not allowed. The Fidelio trial was the first trial with people with albuminuria, as you can see, from 30 to 5,000, GFR 25 to 75. So you can say this was the more advanced kidney trial, and the primary endpoint was a kidney outpoint, and the secondary outcome was a cardiovascular composite outcome. And then the Figaro trial was a trial in slightly earlier type 2 diabetic kidney disease, with more patients with moderately increased albuminuria. And here the cardiovascular outcome was a primary outcome, and the composite kidney outcome was a secondary outcome. And then, as mentioned, these two trials were combined into the Fidelity analysis. And please note that these two trials in combination included more than 13,000 individuals with type 2 diabetes and chronic kidney disease, by far the largest studies we have seen in this area. And for the Fidelity, you could say the design was finerenone compared to placebo. The cardiovascular composite outcome was time to cardiovascular death, non-fatal myocardial infarction or stroke, or hospitalization for heart failure. And then the primary kidney outcome was a doubling of serum creatinine, or end-stage kidney disease, or renal death. And then there was also looked into other outcomes, such as time to death, albuminuria reduction, and a 40% decline in eGFR as part of the composite endpoint. And to make a long story short, interesting and positive, significantly positive data on the cardiovascular outcome on top of this optimized RAS blockade, with a 14% risk reduction in the cardiovascular outcome, corresponding to numbers needed to treat for 3 years of 46. So a very significant improvement in treatment of type 2 diabetes and kidney disease. And if we look at the kidney outcome, there was a 23% risk reduction corresponding to 60 patients having to be treated for 3 years. And again, as you can see, highly significant outcome. So we have both cardiovascular and kidney benefit in type 2 diabetes kidney disease. What about hemoglobin A1C? No change. What about blood pressure? Small effect, 3 millimeters of mercury reduction after 1 year, maybe reflecting that people were quite well treated for blood pressure at baseline, maybe reflecting that finerenone is not as strong as an antihypertensive agent as, for instance, spironolactone, and very important, no breast hyperplasia or gynecomastia. What's of course very interesting is what about hyperkalemia, and there is hyperkalemia with finerenone. And I should remind you that everybody had to have a potassium less than 4.8 to be included in the trial. There was 14% having any hyperkalemia with finerenone and 7% in the placebo group. But actually, hyperkalemia in this trial was very easy to manage. The drug has a short half-life. You can stop the drug. You can change diet, add diuretics. And actually only 1.7% of the participants had to stop because of hyperkalemia compared to 0.6% in the placebo group. And there was importantly no death related to hyperkalemia in these 13,000 patients treated for on average 3 years. So to monitor this, it is recommended that you monitor potassium 1 month after initiation of therapy, and then every 4 months. That was how it was done in the trial. There was no specific recommendations on how to deal with potassium, but investigators could do this at their discretion. Just for comparison, I'll show you data from the AMBER trial and the Fidelio trial. AMBER was a trial which was a trial in hypertension and chronic kidney disease, where spironolactone with potassium binder patiromer was compared to spironolactone to placebo. And as you can see, 35% within 3 months, 12 weeks, had hyperkalemia with a potassium binder, and 64% without a potassium binder in 12 weeks. Whereas in Fidelio, with notably little better kidney function at baseline, 44 versus 36, these numbers were much, much smaller. At a comparable time window, it was 4.5% with finerenone and 1.6% with placebo, suggesting that finerenone gives indeed much less hyperkalemia than, for instance, spironolactone. So the treatment recommendations, and I'll mention them because it's such a new drug, that is you should start with a potassium less than 5, start on the low dose if GFR is below 60, and you can go for the high dose, 20 milligrams, if you have a GFR above 60. And if you start on 10, you increase the dose unless potassium is above 5.5. If you come above 5.5, you take a pause until it's below 5 again. Now, interestingly, what happened for those treated with an SGLT2 inhibitor? This is not a randomized trial, but within the Fidelio and Figaro trials, there was almost 900 people treated with an SGLT2 inhibitor at baseline. And if we look at the response to finerenone in those treated with an SGLT2 inhibitor compared to those without an SGLT2 inhibitor, you could see that those treated with an SGLT2 inhibitor, they had somewhat lower albuminuria at baseline, and in both groups there was a significant reduction when adding finerenone, and actually this reduction in albuminuria was in relative terms a little bigger if you were on an SGLT2 inhibitor than if not, which could suggest that these two agents can be combined. Of course, this is, as I said, not a randomized trial, so the trial is just being started, but the promising data, I would say. Even more promising is if you look at the hard outcomes, Definitely the trial was not powered to evaluate this, but as you can see, both the cardiovascular outcome and the kidney composite outcome, there was no interaction with SGLT2 inhibitor therapy, and if anything, it was in the direction of a good effect when combined, suggesting that maybe we should treat patients with both an SGLT2 inhibitor and finerenone, but of course that needs to be further studied. These all these exciting data where we have seen SGLT2 inhibitors and finerenone showing good data have led to updates of guidelines. This is from the American Diabetes Association. They every January issues guidelines, and this year they devoted a chapter to chronic kidney disease and diabetes, where they recommend SGLT2 inhibitors, but where they also recommend that finerenone is now available and recommended if you have high cardiovascular or kidney risk in patients with type 2 diabetes and chronic kidney disease. And the finerenone was available and approved in the US last summer, and it was approved in Europe by EMA last month. So now we can also start getting access to finerenone. And therefore, in the recent updated draft of the KDIGO kidney disease and diabetes management guideline, we had to update and not had to, we were pleased to be able to add the non-steroidal mineralocorticoid receptor antagonist with proven benefits, which is only finerenone, into this algorithm. So again, this algorithm includes healthy diet, a healthy lifestyle. It includes metformin, SGLT2, RAS blockade, statin therapy, and then finerenone for people with type 2 diabetes and kidney risk. And they have all this. And then, of course, also the control of risk factors, glucose, blood pressure, and lipids. So really important. This is, as mentioned here on the slide, a draft. So we'll have to wait and see how the final figures and text will be. But I'm sure that we will maintain and see future guidelines and other guidelines adding these new agents to the recommendations. So to sum up from the previous KDIGO guideline, we should have a comprehensive care. We should monitor glycemia and set ambitious targets, but be aware of hypoglycemia risk. We should focus on lifestyle, and we should make patient-centered decisions with shared decision with the patient. We should have education of patients about their disease, and we should have focus on diet and healthy lifestyle. And then we should take advantage of the new agents, SGLT2 inhibitors, GLP-1 receptor agonists, and for the new guideline, also, of course, finerenone. So to conclude, we have seen that RAS inhibition, SGLT2 inhibitors, metformin, and statins were recommended as first-line therapy. We have seen that we should screen for kidney disease, both with eGFR and albuminuria, and now finerenone is added as a non-steroidal mineralocorticoid receptor antagonist with both chronic kidney disease and cardiovascular benefits on top of the other agents. So maybe we are going to a situation, and we have for so many years, we've only had one option, blocking the renin-angiotensin system in chronic kidney disease. Now we are approaching what the cardiologists in heart failure have had for a long time, multiple options that need to be implemented. So probably people would need to have SGLT2 inhibitors, mineralocorticoid receptor antagonists, blockade of the renin-angiotensin system, and maybe in the future also GLP-1 receptor agonists. And then just a note that there are differences between the steroidal and non-steroidal mineralocorticoid receptor antagonists. We have no long-term outcome data with the old steroidal ones, and we have beneficial effects with the new ones. And then a key point, finally, is that implementation is a big problem. I mean, no successful studies is of any good if we don't implement all these new successful findings. And it has really been fantastic to see how we in a few years suddenly have seen so many successes, but we certainly also need to find kidney disease and treat kidney disease as early as possible with this new armamentarium. So with this, thank you very much. This is a picture of our new Steno Center, and I look forward to have a hopefully engaged and lively discussion and look forward to that.
Thank you so much, Dr. Ressing, for such an insightful talk and for the thorough review of the recent guidelines and trials. It's really encouraging to see such large number of audience. We have around 1,500 participants joining us tonight. And we are doing well in terms of time. So if you allow me, I'm going to go through some of the audience question. And well, I know that you've already talked about that, but one of the common question from nephrologists is, what is the best order to start these agents? RAS blocker, SGLT2 inhibitors, finerenone?
Yeah, thank you. That's an excellent question. And the challenge is, of course, that the trials were done on top of RAS blockade. So that's probably where we should start, ACE inhibitor, angiotensin II receptor blocker. And then you could say the SGLT2 inhibitor trials and the finerenone trials were done in parallel. So the SGLT2 inhibitor trials didn't include finerenone, but they include some MRA treatment for heart failure, and showed, just as I showed for the finerenone trials, that when you add an SGLT2 inhibitor, you get the same benefit whether you already have a mineralocorticoid receptor antagonist on board or not. And reversely or conversely, you can say in the finerenone trials, they also suggested that they could be added to each other. I would say if you, and maybe an interesting point I should mention is that it seems you have less problems with hyperkalemia if you have the combination of finerenone and an SGLT2 inhibitor. So in that sense, it is really a combination that provides more benefit and less side effects. And then what should you do? Well, actually right now a study is started called Confidence, which will test either an SGLT2 inhibitor or finerenone or the combination. And that might learn us something of use in this situation. But until we have the results from that, I think if you have high potassium, you would start with SGLT2 inhibitor. If you have a regular patient with CKD, then you could start SGLT2 or finerenone as you would like, and I would go for combination quickly. But I think for the moment, until we have a little more data, I would not start both of them at the same time, because both actually can give a little dip in GFR when you initiate therapy, and we don't know if this dip is larger if you start two drugs in one time. We know from particularly both the SGLT2 inhibitor trials and the finerenone trials, this dip is not dangerous, and it's not as we know it from when you start an ACE inhibitor, for instance, that you should be concerned of renal artery stenosis, but it probably reflects a hemodynamic effect of the drugs. And we know from the SGLT2 inhibitor trials, if you have this reduction or if you don't have this reduction, it is not really related to your outcome. And if anything, a small reduction may be successful or may be reflecting that you actually have a benefit on the glomerulus. So my recommendation would be start with the traditional RAS blockade, and then add one of these agents, and then soon after add another agent. Some guidelines will probably say SGLT2 inhibitors first because they were first in guideline. You can say that was by chance because the SGLT2 inhibitor trials finished a little earlier than the finerenone trials. And you could also say that we got initial data from the cardiovascular outcome trials on SGLT2 inhibitors. On the other hand, you could say if you are a little uncomfortable with glucose lowering agents and what is it about lowering glucose with the SGLT2 inhibitor, and should you be concerned for hypoglycemia and so on, I don't think you should do so. And if you are concerned, you could talk to a diabetes doctor like me, but otherwise then you could start finerenone and then you don't have to worry about that. But then you just need to monitor potassium, as we do it anyway in our patients with CKD, because for any it is a risk with hyperkalemia. So I think that the recommendation is I would try to get them both on board, or all of them on board, but not at the same time.
Sounds good. Thank you so much. So as you know, the focus now is on SGLT2 inhibitors and finerenone. So most of the questions are about those medications. So one question is about acute kidney injury post SGLT2 initiation. He's mentioning that during Ramadan fasting, we are observing a higher rate of AKI with the use of SGLT2 inhibitors. So any thoughts on that?
Yeah, it's very interesting because in the trials with SGLT2 inhibitors, there's clearly an increased risk, not a big risk, but an increased risk for dehydration. And of course, if you have a period of fasting like Ramadan, then you might be at particular risk. But interestingly, in the trials, despite this increase in dehydration, there is less acute kidney injury in the trials than there is with treatment with an SGLT2 inhibitor than without, suggesting that the initial small dehydration effects we see is not causing AKI. That's not to say it cannot happen, and if you are in this special situation, particularly of course if it's very hot and you are dehydrated, that may be something to be cautious about. And then could say it has been debated, should you reduce diuretic agents? And in general, that's not recommended, but if you're on high dose diuretics, it may be wise to reduce the diuretics or stop the diuretics if you start an SGLT2 inhibitor. But you could also then say, well, start a finerenone instead. The risk is probably smaller here.
Perfect. So there's also a question about, is there an ongoing trial where treatment of for treatment of hyperkalemia in patients with finerenone with batiromere or sodium zirconium instead of interrupting the treatment?
Yeah, that's an excellent suggestion. You could say in the trial, Fidelio and Figaro, it was possible to use potassium binders, but it was not done in a systematic way, and it was very rarely done. And I'm not aware of a trial testing this hypothesis. If you could continue finerenone longer, or if you could to get kind of the sustained benefit without having to stop in patients with hyperkalemia. And I think it would be an interesting trial. And I think really we need trials with the potassium binders showing that they not only lower potassium, but by allowing, as the AMBER trial I showed with spironolactone and batiromere showed, that it seems you have a smaller risk for hyperkalemia when you combine them, and therefore you are allowing treatment for a longer period of time. And we would expect that translate into long-term benefit, but it would be good to have these data as well.
Perfect. Also about trials, are there any ongoing trials for using SGLT2 inhibitors in other than diabetic kidney disease? Now, I think I'm aware of some trials in IgA nephropathy, but are they extending that to other forms of glomerulonephritis?
Yeah, that's an interesting question, because you could say there was these data with SGLT2 inhibitors in diabetic, non-diabetic kidney disease. For finerenone, there will also be trials in non-diabetic kidney disease and in heart failure with preserved ejection fraction. And for the SGLT2 inhibitors, there are currently, to my knowledge, discussion on a trial in kidney transplant patients and in dialysis patients, actually, where it's going to be investigated if that would be beneficial for the heart. Of course, if you are in dialysis, there's not much kidney benefit to expect, but maybe you could have heart failure benefit still. And therefore, there are yet more trials to come. And I think both the dialysis population and the transplant population are important populations which are usually neglected in the large trials. So therefore, it will be important to gain more information on these populations.
Perfect. Also a question, can we start SGLT2 inhibitors and GLP and from the start?
Yeah, you can say initially we have always said, or when I say we, endocrinologists said start with metformin and then give SGLT2 or GLP-1 if you have cardiovascular or kidney disease. Then the cardiologist actually started by saying, well, maybe you don't need to start with metformin. The evidence base for metformin is not that strong. So maybe if you really have kidney or cardiovascular problems, then start with the drugs that we really know work. You can, on the other hand, argue that metformin was used as foundation in all the other trials. But there is evidence that it actually doesn't matter if you're on metformin or not to see the benefits of these new drugs. And therefore, I think the direction of different guidelines is going in a direction where you're saying it's really important that you get the organ protective agents and don't waste too much time on lifestyle or on metformin before you get to these drugs. Interestingly, in heart failure particularly, but also to some extent in the kidney trials, you can see the benefit within a month on heart failure patients when you start an SGLT2 inhibitor. So, I mean, you cannot wait 6 months and say, come back in 6 months and then we'll discuss if we should add something to your metformin. It has to happen quickly.
Yeah, that makes sense. Any effect of SGLT2 inhibitors on potassium?
Yeah, as mentioned, interestingly, it seems that the SGLT2 inhibitors lower potassium or risk of hyperkalemia at least. And that has been seen in heart failure trials with the steroidal mineralocorticoid receptor antagonists. And it was also seen in the Fidelio trial with finerenone when looking at the subgroup treated with SGLT2 inhibitors compared to those without, suggesting that, as I mentioned, this is actually a win-win situation where you get the added benefit and less side effects. That's really a rare combination. Usually you'll get more side effects, but more benefit. If you're lucky, here you seem to get more benefit and less side effects. So that's really unusual and something I think I hope we can see applied much more.
Perfect. We still have 2 minutes, so allow me to take last 2 questions. Any data on the safety of SGLT2 inhibitors in pregnancy and lactation?
No, that should not be used.
Okay. Is there an impact of SGLT2 inhibitors on nephrolithiasis? Some reports suggested that it may have role in preventing renal stones.
Yeah, I'm not aware of good data in that area. I cannot say it doesn't have that effect, but it has also been debated in the transplant population if that would be a benefit or if it would actually cause more complications. But I'm not aware of good data to elucidate that. It has not been seen in the kidney trials that there was any difference. But whether real-world data could show such effects in much larger populations would be interesting to see.
Okay, and there was a question about, well, he's asking which is better approach, to use the highest tolerable dose of RAS or to use like a usual dose of RAS plus an SGLT2 inhibitors?
Yeah, I think the foundation of all trials is maximum tolerated dose of RAS inhibition. So the trials would suggest that the higher the dose, the better the effect. So if tolerated, you should go for the highest dose. You could then say that what may limit up titration of RAS blockade could be hyperkalemia, and then by adding an SGLT2 inhibitor, you could mitigate that risk, or you could allow you to combine with finerenone. So I think that in general, we would go for a high dose. That was also the foundation of the finerenone trials, highest dose of RAS blockade, and then add the newer agents on top of that.
Perfect. I think we'll have to stop here. I apologize for those who I couldn't address their questions because of time. But was very, very fruitful, very insightful talk. I would like to thank you again, Dr. Ressing, for being with us today. And I hope that we'll have you again in on site, like not virtually, hopefully. And hopefully we'll see everyone again in upcoming activities by the society. Thank you so much, Dr. Russell.
Thank you very much for the opportunity to be here with all of you, and thank you for those who attended. And it was a great pleasure. And indeed, I look forward to meet you live.
Thank you so much. Thanks, everyone.
Okay, thank you very much. And thanks, Professor Rossing, and thanks, Dr. Muthanna, for wonderful talks today. And the talks will be shortly in the YouTube channel of the Society. And we'll meet you, inshallah, after Ramadan for another webinars, inshallah. Thank you very much. Ma salama.
Thanks.